We wanted to start out with an introduction as to what cerebral palsy is, and in summary, it is alterations in the brain that impacts balance and posture, and in doing so, it also alters the individual's ability to move. Symptoms can range on a spectrum from mild to severe, with the more severe cases, the individual is not able to walk at all. More milder ones, they can be basically fully functioning, just having minor gait issues or balance problems. It's these patients with the milder forms of cerebral palsy where physical therapy might be the most effective. It's important to note that it's also very common for patients with cerebral palsy to also have things like intellectual impairments and speech issues that should most definitely be taken into account when considering treating these patients. Concerning diagnosing cerebral palsy, this is normally done in early childhood, and the primary indicator for this is delays in reaching or movement milestones during the first few years of the infant's life. If a parent notices that their child is behind the normal movement milestones, the next steps that should take is to seek medical help, where they will first receive a clinical screening for cerebral palsy, and if by doing this they are in fact diagnosed, a physician will look further into the case to determine which specific type of cerebral palsy the child has. It should be noted, though, that delays in reaching movement milestones alone does not mean that the child has cerebral palsy. And it's actually pretty common for children to be delayed at certain points along their development as they mature at their own unique rate. There are four different types of cerebral palsy, each having its own unique attributes. They are spastic, dyskinetic, ataxic, and mixed. Spastic is the most common and is characterized by increases in muscle tone. Dyskinetic indicates issues with controlling the movements of the hands and limbs, making walking and sitting very difficult. Ataxic has problems with balance and coordination, leading them to be pretty unsteady when they walk. And last is mixed cerebral palsy, and this is characterized by having symptoms of more than one of the above mentioned types of cerebral palsy. But the most common form of this is spastic dyskinetic cerebral palsy.
All right. Thank you, partner, for the introduction, and howdy, folks. What we're going to be getting into now is the first article. It's all about gait patterns, and the title of it was Gait Analysis in Children with Cerebral Palsy. The purpose of this article was to review the main gait patterns typically seen in children with cerebral palsy and the importance of gait analysis in this. The methods was just really critical appraisal and review of the literature surrounding gait analysis in cerebral palsy patients. And the image here I've attached on the slide is just for your reference of a typical gait cycle. Alright, so the first few gait patterns we're going to be going over are all unilateral, and this first one is called drop foot. This is defined by a lack of dorsiflexion at the ankle with an angle of the ankle that is greater than 90 degrees at initial contact. All this means is that it's essentially plantar flexed, and this limits the smooth rocker motion that we would normally get, and it can basically be not present at all anymore at initial contact because of the presence of plantar flexion instead of dorsiflexion. This gait deviation also results in overactive plantar flexors, namely the gastrocnemius and soleus, and a weak tibialis anterior, which is the primary dorsiflexor. The next gait pattern we're going to be looking at comes from the gait deviation known as true equinus. This means horse-like, and the same drop foot is present, although it is permanently plantar flexed. The foot is permanently plantar flexed, and this can lead to the development of contractures in the plantar flexors. Some variations of true equinus are known as true equinus with recurvatum in the knee, which just means knee hyperextension, and then true equinus with jump knee. Jump knee is a little bit more involved as it has limited knee flexion in the swing phase and excessive hip flexion and lumbar lordosis to compensate for that. Because of this, there are possible contractures at all three of those joints instead of just at the plantar flexors and ankle joint with true equinus. So true equinus with jump knee can also see contractures not only at the ankle but at the knee and hip joints. The next gait pattern we're going to be looking at is called hemiplegia. This is a combination of equinus and jump knee with drop foot. So basically a combination of everything we've looked at so far. There's limited knee flexion as well and hip flexion, as well as excessive lumbar lordosis. There's limited motion at the hip and knee, along with pelvic rotation at the hip and adduction and internal rotation at the knee, as you can see in the image on the right side of your screen. This produces a valgus strain on the affected limb, and the compensation made for this is even more excessive back extension, which increases the lumbar lordosis in the patient. Now we're moving into the bilateral gait deviation or gait patterns, and with these we've already been over true equinus, but now there is also apparent equinus. True equinus is defined in the same way, really. Permanent plantar flexion with the hips and knees extended all through stance phase of the gait cycle. That's seen in the first image on the right-hand side there. And then apparent equinus, although in the image it looks pretty obviously different, the way that it's similar is that they end up walking on their toes, much like someone with true equinus, and the apparent equinus pattern has normal amounts of dorsiflexion at the ankle, but they have increased amounts of knee and hip flexion, which is the reason behind them walking on their toes. The next bilateral gait deviation is known as crouch gait. This is characterized by presence of dorsiflexion at the ankle and causes the angle at the ankle joint to be less than 90 degrees. There's also a presence of hyperflexion at the knee and hip, and this hyperflexion in combination with the dorsiflexion causes the patient to have difficulty with the toe-off phase of gait. The final gait deviation pattern I'm going to be taking you through is something we've pretty much already been over. It was bilateral. It's called bilateral spastic jump knee. We already went over it unilaterally in combination with true equinus. We saw true equinus with jump knee, and the characteristics are much the same here. There's hip and knee flexion along with equinus at the ankle and an anterior tilt at the pelvis, which compensates for the previous two characteristics and increases lumbar lordosis.
During first double support, the two most common deviations are an absent ankle rocker and increased knee flexion. During the different stages of stance phase, some of the deviations that can present are early ankle plantar flexion, dorsiflexion that is either increased or completely absent, increased hip abduction, and at the knee could be either reduced knee extension or knee hyperextension. During the loading response, it's very common to see reduced knee flexion. During second double support, limited hip extension is the most common deviation. During swing phase, knee flexion is often delayed or reduced. During the course of an entire stride, some additional common deviations that can occur are external or internal foot progression, increased hip flexion, increased internal or external hip rotation, pelvic tilt double bump, pelvic obliquity up or down, reversed pelvic rotation profile, sustained pelvic protraction or retraction, trunk tilt with double bump, sustained trunk obliquity, or excessive range of trunk obliquity with a Trendelenburg.
Ava was born on November 12th, and she was supposed to be born the following February. So she was very, very small. Ava just wasn't reaching her milestones, like rolling over, sitting, crawling.
Some of the most notable gait deviations that are visible in this patient include excessive lumbar extension and rib external rotation in the trunk area. At the hips and knees, we can see quite excessive valgus, and at the ankles, we can see very pronounced plantar flexion. Although the patient may have many gait deviations, all hope is not lost. With the right combination of surgery and expert physical therapy, remarkable outcomes can be achieved.
The first gait analysis was really crazy because you're in this big room with all these like Hollywood movie cameras around, and then they actually take a child's movement and animate it.
In the gait analysis laboratory, we have a lot of different pieces of technology, but the single piece of most important technology is the ability to measure movement. The way we measure movement is to apply some markers to the body that are reflective, and then you walk through the gait lab. The camera system can see where those markers are in space. So we not only use the Gait lab to help us make decisions, but we can assess individual outcomes. We make all these decisions early on in their lifetime, but the real question then is does it really accomplish those longer-term goals?
I'm looking at this girl who came into Gillette really having a tough time walking, and now she goes wherever she wants to go. I feel proud and excited for her future. Now I know with a little support here and there, she can do whatever she wants to do.
Now, for our second article, we thought we would show you something really interesting that's happening right now in the field of research regarding gait with cerebral palsy. So the title of our article is A Robot-Based Gait Training Therapy for Pediatric Population with Cerebral Palsy, Goal Setting, Proposal, and Preliminary Clinical Implementation. One of the really interesting things that's happening right now is the use of robotic trainers. Now, a robotic trainer is essentially a full lower extremity orthosis that's strapped with a bunch of machinery. And what that machinery allows you to do as a researcher is you can adjust the level of assist that a person is getting as they travel through that gait cycle. This has been used several times in research with especially children with cerebral palsy and training them to use proper mechanics when they walk. So one of the issues right now, though, is that though we have all this really cool research about robotic trainers, we don't really have a good way of implementing that into the clinic. So what Bayonne et al. Proposed is a way for us to take that research that's being done and apply it into a clinical model so that clinicians can pick up this research and make meaning of it.
Here is our PICO question for our article. So the population is children with cerebral palsy. Our intervention is a robot-based gait training therapy called CP Walker, shown in the photo. Our comparison is to regular conventional therapy for patients with cerebral palsy, and our outcomes found that there was an improvement in strength, mean velocity, step length, as well as gait performance. Time-wise, there is a 2 non-consecutive days per week training sessions for a total of 8 weeks. This would bring our total number of sessions to 16. A little more information on CP Walker itself. It is composed of an exoskeleton linked to a walker to provide support and balance. There are 3 modes that can be activated. First one being position control. So this is essentially the robot is able to impose prescribed gait patterns. The aim here is to teach the patients proper walking sequences correctly. The second one is impedance control. This one takes into account the patient's collaborations. So it is a sum of robot assistance along with voluntary muscular control. This can range from high, medium, down to low. Our last mode here is the zero force control. So there is no trajectory references being given to the patient so that the patient is able to move with minimal assist. This is primarily used just to provide balance and stability during gait. As we all know, patients with cerebral palsy tends to have a flexed hip and knee joint. So with the CP walker, the clinician is able to manually control joint angles in these areas so that we can promote better functioning gait patterns. And lastly, the CP walker also has a biofeedback strategy, which can motivate the patients to actively correct posture during gait. And this can also be controlled by the clinician as well. Evaluation metrics used were the 10-minute walk test, a 3D gait analysis, handheld dynamometer, which tests isometric muscle strength, scale, which is to quantify selective voluntary motor control, GMFM88, which tests changes in gross motor function, FAQ, which is a questionnaire regarding independent activities and satisfaction, along with a range of motion performance. The main parameters the researchers were looking into primarily were the range of motion, partial body weight support, and gait velocity. So the intervention itself is broken up into 2 phases. First one being the strength training sessions. So a total of 4 weeks. It is essentially to get the patients used to the program. Throughout the 4 weeks, there is a gradual decrease in the partial body weight support the robot is being provided, along with an amplification of the range of motion. The goal here is also to maintain velocity. Second phase is called the power training sessions. Again, this is 4 weeks. Range of motion is supposed to reach 100% of the intended by the end of week 13. And at that week 13, there's an increase in velocity as well. Throughout the 4 weeks as well, there is a continued decline in the partial body weight support the robot is providing for the patients.
Here on the results section, we have a couple select figures. Now, this isn't all the results of the study, but these are the ones we felt were most important to your understanding of what was done. Figures 3 and 4 list the percent range of motion, percent partial body weight support, and the percent velocity traveled by the CP walker. So the first thing we'll look at is percent range of motion. This is essentially telling you how much of their range of motion available was explored while they were performing the gait cycle. So in the first 8 weeks, they travel from about 75% up to that 100% where they're exploring the greatest range of motion. And then in the second 8 weeks, they drop that back down initially. Now that's probably just a learning phase where they are learning the new protocol that they're being given, and it jumps very quickly back up to that 100% value. The second thing is the partial body weight support. That is essentially how much contribution is being given by the robot to the body weight support. So at 100%, that would be a complete maximal assist. That is where the patient is not contributing anything. They're just going through the motion. They're having that full kinematic exploration, but they're not giving any contribution to the force imparted. So you'll notice in the first 8 weeks, they go from 100% where the machine is completely contributing to about 50%, which would be a moderate assist. And then in the second 8 weeks, they travel from an 80% value down to almost a minimal assist at 30%. Finally, we'll look at velocity of CP walker. That's just how fast it's moving. It travels in the first 8 weeks, not very big improvement from 30 to 33%, but in the second 8 weeks, you see a 35 to 50% bump, which is pretty big. Figure 5 tells you the 6 categories of assistance that the researchers set. Level 1 would be near a maximal assist, and level 6 would be near a minimal assist. So you can see how the different patients progressed through that. And then finally, on the far right, figure 7, we have the strength values given for the different planes of motion. These are given in kilogram force, so essentially the force imparted by the patient at their maximal contraction. And you'll notice the pre-values typically have the smallest volume in the shape. The middle values will have the second smallest value for their volume. And finally, the post will have the largest volume, indicating that the greatest strength measures were seen at post. Here we find a results summarized section where we just present the key results that the authors of the study presented. On average, they saw an improvement in strength of 74.03%, an improvement in velocity of 21.46%, improvement in step length of 17.95%, and an improvement in gait as measured by the GMFM88 of 66%.
When it comes to treating gait deviations in patients with cerebral palsy, our treatments are generally going to strive to limit muscle contractures or bony deformities, which is going to facilitate the fluency and efficiency of our gait patterns. We're going to reestablish our lever arms, again, helping with that efficiency and then facilitating proper muscle function, and then preserving our muscle strength, which we know is going to be a fundamental component of function in general. Some treatments that are going to aim to do this, obviously physical therapy. We're going to be able to address a lot of these deficits, help re-educate on gait, and help to achieve some of these goals listed above. Ankle foot orthoses have been shown in a study conducted in Sweden to facilitate restoring dorsiflexion range of motion, which we know is going to be an essential component of our gait pattern itself. Botox is going to help with the muscle spasticity in cerebral palsy by acting as a muscle relaxer. And those studies have shown that a single treatment with Botox in the lower extremity is able to effectively reduce spasticity bilaterally. And then baclofen medication, which is going to be administered through an intrathecal pump, which is inserted in your abdomen between the muscle and the skin. This is another medication that's going to address the spasticity problems that are seen in individuals with cerebral palsy. And then even there's a number of surgical options out there that can address some of these bony deformities and some of these gait issues that we're seeing in individuals with cerebral palsy. Here's a table for your reference that summarizes some of the surgeries that may be performed in order to address certain gait impairments seen in individuals with cerebral palsy. It's important to understand the nature of these surgeries if you're going to be treating an individual post-operatively. This is going to help facilitate and maximize your treatment options. Some considerations when working with cerebral palsy patients. The first one's going to be age. Just like any patient population, there's going to be some age-specific considerations when you're working with them, especially in the early developmental stages where we're going to be working with a lot of pediatric cerebral palsy patients. You want to incorporate playtime as a part of your treatment and rehab sessions. This is going to help with patient engagement and make things a little bit more fun, not only for the patient, but also for yourself. Second consideration is going to be growth. Just like any individual, as you grow, you're going to have to adapt to your new body, and you're going to have to learn new motor patterns in order to efficiently and effectively move your body about. This is going to be especially prominent in individuals with cerebral palsy who are already experiencing gait difficulties. So you need to take that into consideration and know that it may be a little bit more of a challenge as they have to adapt to this new body they're growing into. And lastly is going to be cognition. 1 in 4 patients with cerebral palsy are going to experience communication issues due to cognitive deficits. You're going to have to adapt to these and find effective means of communicating with these patients. This is going to be a very individualized approach. You're going to have to adapt to each patient that's in your clinic that you're working with in order to effectively address their needs and their goals. So that's going to do it for our presentation. We thank you all for listening today, and we hope we were able to teach you something. Again, we look forward to seeing you in the fall.